eye to eye with thyroid eye disease.
How autoimmune thyroid disorders affect the eye. Chemosis is swelling on the eye's surface, fluid collecting between the outer eye membrane, the so-called conjunctiva, and the sclera, or the skeleton of the eye. Chemosis may appear as a little bubble or blister on the surface of the eye, or as profound bulbous swelling. Chemosis is not dangerous, but may appear quite startling. Just as a reminder, we have already seen some unsettling pictures of very kind people afflicted with thyroid eye disease, who have been supremely gracious and generous in allowing us to learn from their situations. Some of the following images might be even more frightening. Please keep in mind, though, that this lecture series is intended to educate, not frighten. Often extreme examples are shown to make a point. The vast majority of people do not progress to the extremes of the diseases shown. Nobody needs to go blind from thyroid eye disease. In our practice, having treated over 7,000 people, nobody has gone blind. The vast majority of people with thyroid eye disease are returned to a reasonably normal state of being. As we've said, swelling of the conjunctiva is called chemosis. In section 4, we discussed about the underlying changes that occur with thyroid eye disease. We said there was an inflammatory or swelling phase, and that gives rise to a scarring phase. The swelling phase is due to many factors. The swelling in chemosis is no different. The most important are so-called venous pressure, the increased size of blood vessels, so-called vascular dilation, and increased leakiness of the vessels, allowing fluid to seep out of the vessels and into the surrounding tissues. And finally, local inflammation around specific cells. In the case of the conjunctiva in chemosis, we are talking about inflammation of the conjunctival fibroblasts, which are targets for the autoimmune antibodies. All of these factors lead to inflammation and swelling of the surface membrane of the eye, the so-called chemosis. For those interested in reviewing some of the pathophysiology of this process, we offer this diagram, and thank Dr. Dutton for this image. This is what chemosis can look like. Strange swelling on the surface of the eyes. Again, this is not dangerous, but it can certainly be somewhat frightening appearing for those who have never seen it before. Here are some other examples of chemosis. Chemosis is often a sign of active inflammation or an indication that the thyroid eye disease is still in an active phase. In this case, the chemosis is mostly clear or pale. This nice woman shows that chemosis may also appear pink, yellow, or bright red, depending on how much protein or blood is involved. Here are more extreme examples. Again, don't be alarmed. Chemosis in itself is not dangerous. However, as seen in the bottom left-hand panel, if the chemosis is so significant that the conjunctival membrane sticks out between the eyelids on attempted eyelid closure, this can be a problem. Because if the eyelids don't close over the surface membrane of the eye, then the surface membrane, the conjunctiva, may dry out. The more it dries, the more it swells, and the more it swells, the more it dries out, a progressively worsening cycle that would require aggressive treatment. We call this problem, if it occurs, exposure conjunctivitis. Eyelid swelling, also called eyelid edema, occurs in essentially the same way that a person might develop chemosis, enlarged leaky blood vessels and primary target sites for autoimmune antibody attachment and stimulation of inflammation. In fact, since the mucous membrane on the eye's surface, the conjunctiva, is continuous with the mucous membrane on the backside of the eyelid, eyelid swelling may produce chemosis, and chemosis may cause eyelid swelling. In eyelid edema, notice how the eyelids appear soft, soggy, and baggy. This is characteristic of eyelid swelling. If you touch the eyelids, the tissue is soft and will often indent with a finger pressure. The eye socket, or so-called bony orbit, is the space in the skull in which the eye resides. The orbit is filled with many important structures, nerves, muscles, and vessels. All of these structures are suspended in a cushion of fat by fine fibrous bands. Orbital congestion is swelling in the fat behind the eyes. In orbital congestion, there is a fullness behind the eyes. The eyes may or may not stick forward. In mild cases, the eyelids may simply appear bulgy or full, especially the lower eyelids. People will often complain of a tight feeling, pressure behind the eyes, or even pain. These symptoms are often worse in the morning, especially after consuming alcohol or salt the night before, and again at the end of the day. In more extreme cases, the orbital congestion produces very tight, rigid bulges in the upper and lower eyelids as scarred, non-compliant fat prolapses forward. This can be a serious and dangerous sign of thyroid eye disease. Contrast orbital congestion with that of the soft swelling of eyelid edema, which may appear much more dramatic and arresting, but is less vision-threatening. Dysmotility. Dys comes from the Greek and means bad or abnormal. Motility is, of course, movement. In this case, ocular dysmotility means abnormal eye movement and is due to problems with the muscles that move one or both eyes. There are 6 eye muscles controlling the movement of each eye. One to move an eye up, one to move it down, one to move it left, one to move it right, and 2 additional muscles with complex control that allows us to keep an object in focus when we tilt our heads. So altogether, in each person, there are 12 muscles around the eyes, the so-called extraocular muscles, or EOMs. In thyroid eye disease, these muscles may become affected, causing the 2 eyes to either not move in a particular direction or to move unequally. First, the muscles become swollen because they are a specific target themselves for the autoimmune antibodies, and then they become scarred and enlarged. We'll see some x-rays of enlarged extraocular muscles later in this section. Defective extraocular muscles creating dysmotility may cause 2 symptoms. The first, difficulty with peripheral vision. This might be noticed in a grocery store, where one finds that rather than just looking upward, he has to tilt his whole head up to see the objects on the higher shelves. This happens because the eyes won't move upwards by themselves. When walking downstairs or reading, a chin-down head position may be required. Similarly, while driving, whole head turning rather than eye movement may be needed to see to the sides. The second difficulty is double vision. Importantly, this is double vision with both eyes open. If both eyes are not pointing in the same direction, each will be seeing a different image, and the 2 will be superimposed one upon the other. If the eye alignment is not too far off, then the double vision may simply appear as a ghost shadow beside the normal image. There are many different kinds of double vision because there are many different kinds of eye muscle problems. Typical features of double vision in thyroid eye disease are: the double vision vanishes when either eye is closed because then the person is seeing out of only one eye and sees one image only. Typically, with slowly progressive thyroid eye disease, double vision develops first thing in the morning when head and eye socket swelling is the worst, and at the end of the day when our brains tire of making our eyes work together. An indication of thyroid eye disease progression is double vision that lasts longer and longer in the morning upon awakening or begins earlier and earlier in the evening or afternoon. In more advanced ocular dysmotility, either one or both eyes may be pulled out of the center alignment and may be stuck in an off-center position until helped by surgery. As you can see, there are all different kinds of ocular dysmotility that may be caused by thyroid eye disease. There are just 2 more clinical features of thyroid eye disease that we will discuss, and in some ways these are the most important to understand. The first is bulging eyes. For many people, bulging eyes is what they think about when they think about thyroid eye disease. But as you now know, eye bulging is but one feature. Eye bulging is rarely called that in medical circles. More often it is referred to as eye or ocular protrusion, or most commonly as proptosis, but also frequently as exophthalmos, literally meaning out eye. Although thyroid eye disease is always a bilateral disease, that is, it always affects both eyes, it is often an asymmetric disorder, meaning that one eye may be more affected than the other, and so only one eye may appear proptotic. Or both eyes may be proptotic, with one eye farther forward out of the head than the other. Thyroid eye disease is the single most common cause of monocular, one-eyed, proptosis, accounting for 20% of all cases, and the single most common cause of binocular, both-eyed proptosis, accounting for 80% of all cases. When we are measuring the degree of proptosis, also called exophthalmos, we find a bird's eye or worm's eye view the most helpful. That is, photographs looking down upon the eyes from above or up at the eyes from below. It's easy to see if one eye is farther out than the other using this approach, and with just a little practice, the distance relative to the forehead, lateral orbital rims, and each eye's projection relative to the other is easily and accurately estimated. Most physicians rely on serial measurements with devices called exophthalmometers, which are designed to measure how far the eyes are out of the head. Our experience has been that these measurements with these devices are notoriously inconsistent and unreliable. The measurements depend upon the devices resting on tissues near the eye. As there is more swelling around the eye, the exophthalmometers measure less proptosis. Tissue swelling around the eyes is a frequent and variable occurrence with thyroid eye disease. The amount of pressure applied to the instrument, that is, how far into the tissue it sinks, is another variable. Additionally, these devices require perfect facial symmetry of the underlying skull, something we rarely find. Here, for example, is a cartoon representation of two pairs of eyes resting in their eye sockets, depicted by the red lines, as though we are looking at the two people's eyes from below. The right eyes on the left of the picture, and the left eyes are on the right eye of the picture. Lines drawn parallel to the floor show that both pairs of eyes are at equal distances out of the head. An exophthalmometer resting on the bones around the upper pair of eyes shows both eyes to be equidistant or the same distance out of the head. However, an exophthalmometer resting on the bones around the eyes on the right indicates a big difference in the relative positions of the two eyes. The left eye is measured to be much farther into the head than the right, even though both are at the same position. This results in the left eye being termed enophthalmic, or farther back in the head. The reason for this discrepancy is that the bones surrounding the eyes are not the same. There is not perfect facial symmetry. Here is an example of a man who is measured to have equal exophthalmometry readings. One can easily see, however, that the left eye is much farther back in his head than his right. The measurements are not reliable. Because the bones around the eyes are at different positions as well, exophthalmometers were popularized before digital photography was available, but we find serial standardized photographs to be much more helpful in both quantitative and qualitative assessment. Like everything else in thyroid eye disease, the degree of involvement varies considerably from person to person. The degree of proptosis may be mild, as seen in this young woman's left eye on the right of the photo. The proptosis may be more moderate and involve mostly the right eye, mostly the left eye, or both eyes equally. In more advanced proptosis, the eyes are essentially out of the eye socket. In severe proptosis, the eyelids can sometimes get stuck behind the eyes, an often painful and vision-threatening problem. This is sometimes called prolapse severity, as the eyes prolapse out beyond the eyelids. Overall, prolapse severity is quite uncommon. The vast majority of people never progress anywhere near this level. However, prolapse severity is not so uncommon in experienced practices, and like all forms of thyroid eye disease, it is fully treatable if addressed in a thoughtful and timely fashion. You may be wondering still why the eyes bulge in thyroid eye disease. What causes proptosis? We've touched on this answer already several times, but to summarize, there are 3 reasons. Increased volume from swelling and orbital congestion, which may later turn to scar tissue. The production of brand new fat cells. Certain cells in the orbit, called orbital fibroblasts, actually change into new fat cells. This is actually an amazing event. It's kind of like saying that an arm turns into a leg. So there is increased volume behind the eye. Third, the extraocular muscles that move the eyes swell and then scar. Both the swelling and the scarring increase the volume, but not the strength or the effect of the muscles. So that you can really understand what's happening to the muscles in the areas behind the eyes, let's spend a few minutes talking about a special kind of X-ray called a computed tomography, or CT scan, also called a CAT scan. This is not like a regular X-ray that you might get of your chest or a broken arm. The X-ray data is acquired and then processed by a computer to create all kinds of specific types of images that might interest us. Here we see a head with a plane going through the head perpendicular to the floor and roughly in the same plane as the front of the face. This is called a coronal plane. In this drawing of a skull, a portion of the front part of the skull is cut away, roughly in the orientation of a coronal plane. A CAT scan can produce a series of images as though we've taken a head and sliced it like a loaf of bread and are then able to look at each slice of bread or slice of the head. Like all X-rays, bones show up as white, hair is black, and soft tissues are gray. You can see how the drawing compares well to the CAT scan image. Here we see the ethmoid sinuses filled with air lie between the eye socket and the nose. This funny-looking blob, called a turbinate, actually resides in all of our noses, increasing the moist surface area of the mucous membrane in your nose in order to make the air we breathe through our nose less dry. Here is the air-filled maxillary sinus that lives underneath the eye socket. Notice that the roof of the maxillary sinus is the floor of the eye socket. The eye socket, also called the orbit. Finally, here is the orbit in which the eye resides. Hopefully you are now oriented to this CAT scan image, and will walk through a series of coronal CAT scan images of the orbits where the eyes live to make a few points. Remember, white is bone, black is air, and gray is a soft tissue density between that of bone and air. Here we see the front of the skull in the forehead and the edge of the soft tissue nose. You can see the nostrils. This is not air in the brain, this is the frontal sinus, the left frontal sinus. The images you are looking at are as though you're looking at another person, not yourself in the mirror. So this person's left side is in the right side of the images. Now we see the frontal sinus on the right as well, more of the nose, and we are starting to see the soft tissue of the brain surrounded by the bony skull. You can also just begin to see the very front part of the left eye. The left eye is now more clearly visible, and if you look closely you can see the denser lens in the middle of the eye that helps us to focus our eye. Why do we see just one eye? Because this person was not perfectly straight in the scanner, but this can also happen if one eye is out farther than the other. The fact that we now see the left cheek without the right ones further suggests that this person was tilted a little bit in the scanner. You can begin to see the front teeth of the upper jaw. The right eye and lens are now more visible, as are the ethmoid sinuses that live between the eye socket and the nose. The lower teeth can now be seen as well as the air-filled maxillary sinuses that lie below the orbits. Notice how as we go farther back in the skull, the orbits get smaller and smaller. Also notice again how the roof of the maxillary sinus is the floor of the orbit. In the left eye socket or orbit, we are now behind the left eye. You can see a central circle. This is the optic nerve that connects the eye with the brain. All signals of sight from the eye must travel along this nerve. If this nerve is damaged, the eye cannot see. There are 4 other oval-shaped blobs in the orbit lying along the edges. These are the 4 of the 6 muscles that move the eye, the so-called recti muscles that move the eye up, down, left, and right. The farther back we go, the smaller the orbit or eye socket gets, because the eye socket is shaped something like a cone, big at the front and small at the back. Now the orbit is even smaller, and notice how there is very little room between the optic nerve and the recti muscles. Previously we looked at coronal images of the orbits. Now let's look at images in a different orientation, that of planes that are more or less parallel to the floor and the ceiling. These are called axial images. You can think of this CAT scan image as looking either down upon or up at a person's head. We see the 2 eyeballs facing upward, with the nose filled with air from the ethmoid sinuses, in between the orbits. You can see parts of both optic nerves traveling down the centers of the orbits to the brain. And you can see parts of the 2 of the recti muscles in each orbit, the muscles that move the eyes left and right. A line drawn from the outer edge of the orbit to the curve of the nose bone should pass through the front half or third of the eye. This is one way that we can judge the degree of proptosis. Note, by the way, that the area behind the eye surrounding the optic nerve is not quite as dark black as the air in the ethmoid sinuses. That's because the area behind the eye is not filled with air, but with fat. Since fat is not very dense, it appears much lighter gray than the eye or the brain, for example. Here we see an axial slice from a CAT scan of a person with thyroid eye disease. We can see the eyes, the lenses in the eyes, the optic nerves connecting back to the brain, and the extraocular muscles that move the eyes right and left. Note how far forward out of the orbit the eyes are, well beyond the imaginary line we drew before. This person has very obvious proptosis. This is a fairly normal-sized extraocular muscle. One can see that this other muscle in the same orbit, however, is greatly enlarged due to scarring of the muscle, as happens in thyroid eye disease. The other two muscles in the other orbit are also considerably larger than they should be. Here are some CAT scan images from other people with thyroid eye disease. Some are axial images, some are coronal images, and there is even a sagittal image, the one at the bottom right, where we are seeing the orbit from the side. Notice how asymmetric thyroid eye disease can be. Sometimes all of the muscles in an orbit are enlarged, sometimes only one. Sometimes the muscles of both orbits are equally involved. Sometimes the degree of involvement appears quite different. Now perhaps it's more clear why the eyes may bulge forward and why the eye muscles may not work very well. The last feature of thyroid eye disease for us to discuss is optic neuropathy. In a very real sense, this is the most serious manifestation of thyroid eye disease if it occurs. As you know, the brain receives information from the eye by the optic nerve, the cable that connects the eyeball to the brain. Optic neuropathy is damage to the optic nerve. If the optic nerve is damaged, then there is no sight. Early optic neuropathy and thyroid eye disease can often be reversed, but prolonged nerve injury may be permanent. Thus, protection of the optic nerve and rapid reversal of any optic neuropathy is the single most important management issue in treating thyroid eye disease. There are two types of optic neuropathy in thyroid eye disease. The first is compressive optic neuropathy, where the optic nerve is squeezed or compressed. Let's briefly review the anatomy. We've already seen this anatomy from the X-ray or CAT scan perspective. As we've said, the eye resides in a bone recess in the skull called the orbit or the eye socket. The orbit is roughly cone-shaped, big in the front and small at the back, as we saw in the CAT scans. Within the orbit or eye socket, there are many structures important for the normal functioning of the eye, among which are the 6 extraocular muscles that move the eye. One sees that the muscles come together at the area at the orbit farthest back from the face, where the eye socket is smallest. Through the middle of the eye socket, between the muscles, runs the optic nerve. We can appreciate that at the back of the rigid bone eye socket, there is not much room for the optic nerve, and if the extraocular muscles get very large, they may crush the optic nerve. Here once more is an axial CAT scan image of an average unaffected person. Notice the normal position of the eyes and the normal-sized muscles. On the left now we see a CAT scan of a person afflicted with thyroid eye disease, in which the extraocular muscles are significantly enlarged. Also notice how far out of the orbits the eyes are sitting. At the back of the orbit, the so-called orbital apex, where the extraocular muscles are tightly packed together along with the optic nerve, enlargement of the muscles may cause squeezing pressure on the nerve. One can see that there is very little room for these optic nerves. Here are shown other examples of muscle enlargement with optic nerve compression. Notice that in the image on the bottom right, the extraocular muscles are huge, but the eyes are not protruding very far. There is minimal proptosis, if any. Yet in the third image on the top right, the muscles are about the same size and there is significant proptosis. Whether or not there is proptosis is a result of the size of the orbits and the degree of muscle and fat change. When the optic nerve is squeezed, it may cease to function and vision can be lost. Looking into the eye with special lights and lenses, a physician may see a bulge at the end of the optic nerve, like toothpaste being squeezed from its tube. This, however, is not often apparent, because as you can see, the bulk of the nerve compression is usually far back in the eye socket, and changes in the optic nerve are generally not visible. We've talked a lot about muscles squeezing the optic nerve, but sometimes people with thyroid eye disease develop signs and symptoms of optic nerve compression with vision loss, and the CAT scan does not show significant optic nerve compression by the extraocular muscles. Compartmentalized swelling within the fat can compress the optic nerve as well. Optic nerve damage may also occur simply by overstretching the optic nerve. This is an infrequent cause of thyroid eye disease-related optic neuropathy that occurs when the eye is pushed too far forward by the enlarged muscles, new fat cells, and swelling. Once again, we are looking at an axial CT scan image. Recall that this line should pass through the middle to the front third of the eye. Here the eye is quite a bit farther forward than it should be. The eye is fully out of the orbiter socket. However, the optic nerve is not tightly stretched, but instead has some slack with natural curvature. So we can say that this is an optic nerve at risk. If there's much more swelling, then the nerve may become stretched. Notice that the muscles are not all that large. In this person, the thyroid eye disease is mostly an accumulation of new fat. Mild stretch neuropathy may be indicated by an optic nerve that is straight and taut. There is no natural curvature to the optic nerves. Again, notice how far forward the eyes are, and how on one side the muscles are quite a bit larger than on the other side. This image is actually an MRI, not a CAT scan. You'll notice in this image the eyes are dark, the fat is bright, and the bone is black. Moderate stretch neuropathy occurs when the optic nerve is so tight that there is a little distortion of the shape of the eye. In severe optic neuropathy, there is significant deformation of the shape of the eye. As the eye is pushed forward and the optic nerve is tethered, it is pulled backward. In general, people with stretch neuropathy tend to have more new fat and orbital swelling than muscle enlargement with their severe disease. Otherwise, they would probably have compressive neuropathy. In Section 5, we talked about how thyroid eye disease affects many end organs in the body, not just the eyes and the thyroid. We talked about how it can affect the brain. In rare cases, these changes can lead to frank psychosis. For many people, a thyroid hormone imbalance precedes or is coexistent with eye changes. The hormonal changes in both men and women may be associated with a dark cloud of many symptoms, including fatigue, anxiety, depression, bloating, weight loss, constipation, diarrhea, irritability, etc., making them both personally miserable and difficult to live with, in some cases producing isolation and diminished interpersonal support. Often people feel terrible long before their thyroid imbalance or thyroid eye disease is recognized. Then they are told they have a lifelong problem, and even though their thyroid hormone abnormality may get addressed, if their eye disease is active, a waiting period is required before treatment can be instituted, allowing their eyes to appear progressively worse and leading to a frustrating alteration in self-perception. The period of active eye change may last up to 5 years. As their sense of original self fades, sometimes a sense of hopelessness and a loss of control can become overwhelming. In living and working with people with thyroid eye disease, it is often useful to keep in mind their psychosocial turmoil. Before developing thyroid eye disease, this young man was a model. His face was his livelihood and his identity. Changes in his appearance were devastating. He stopped thinking about who he really was and focused on what he thought he had become. He felt out of control. He felt monstrous, unwilling to see even his friends. The importance of the psychological issues associated with thyroid eye disease cannot be overstated. We've talked a lot about the multiple changes that may occur with thyroid eye disease, and there's a lot to remember. Let's briefly review the essential points of this video section. The eye changes with thyroid eye disease can be numerous and vary widely in severity from eye to eye and from person to person. Most people never develop the most severe extremes of the disease. Yes, thyroid eye disease can be blinding and painful, but thoughtful management by a knowledgeable physician in our practice has always provided comfort and prevented vision loss. That concludes this video section of thyroid eye disease. In the next section, section 7, we will discuss the active and inactive phases of thyroid eye disease.